think I've just seen a few other people being admitted. So welcome everybody. Sarah has kindly started the recording for this primary care commissioning committee. So my name is Debbie Bartlett. I'm the local authority member of the Integrated Care Board for Norfolk and Waveney, and I chair this committee for the ICB. So great to have so many people. We need lots of interest in primary care, so this is really encouraging. We've got our agenda, and there are one or two items for us to go through, and then recognising that a number of you on this call will be here for the item on Holt medical practice, which is great. So we will get to that fairly swiftly, and then I'll introduce and talk about how I propose to handle that item when we get there. So apologies for absence. I wonder, Sarah or Sadie, if you could just let us know who we've had apologies from today.
Sarah, could I ask you to do that, please?
Yeah, I've definitely had apologies from Stephen Course, and I think we've got James Granger here for him today. Just trying to find the rest. Can't find the rest. Hang on a sec, I'll get back to you in a second.
Okay. All right, Sarah, thank you. Okay, so that takes us to declarations of interest. I'm assuming there are no. Oh, James.
Yes, good afternoon. Thank you, Chair. Councillor James Reader from Suffolk County Council. I just need to tell the committee that as of the weekend, I'm no longer Cabinet Member for Children and Young People Services at Suffolk County Council, but through negotiation or discussion with the Health and Wellbeing Board, who actually asked me to and appoint me to this committee, it was suggested in the interim that I continue to attend this meeting until perhaps some other appointee is made. So just want the committee to be aware of that. Thank you very much, Chair.
Okay, all right. Thank you, James. That's really helpful to know, and we can log that. Thank you. Okay, but aside from that, I'm assuming there are no further declarations of interest, in which case we'll move on to the minutes and the action log from our last meeting in December. So you should all have sight of the minutes. I wasn't planning on going through those in detail. As always, they are great minutes. Thank you, Sarah. I sometimes do wonder how you manage to capture all of that. It's really, really good record. Thank you. So I'm going to suggest that we take that as a true record, unless anybody disagrees. And then I was going to ask Sadie if you would just talk through, I think there are just a couple of fairly straightforward actions from that.
Thank you, Debbie. So yes, we only had a couple of actions from the last meeting. The first one was simply around the minutes, which Sarah has completed. And the second one was on the risk register and thinking about considering the score and time frame for the dental risk. So may I suggest that we pick that up under the risk when we review that item?
Yeah.
Thank you.
Great. Okay, thank you. Okay, so that takes us to our forward planner, where we just have the opportunity to sort of see some forthcoming attractions. And I don't know whether anything has changed since the last time we looked at this, Sadie?
So nothing to highlight really in terms of changes. The only thing I wanted to note was that we currently have the dental strategy and workforce plan down to come to the March meeting, but due to the piece of engagement work that's happening at the moment that that doesn't quite fit in terms of the timeline, and we'd like to fully complete that piece of work first. So it's likely that that will come to the next meeting of the committee after that.
Okay, all right, thank you. Helpful to adjust the plan accordingly then. Okay, so that does take us to the risk paper. So I'll open it up for comments. Or Sadie, is there anything in particular you wanted to highlight to us?
Yes, thank you, Debbie. And if I can go first for general practice and then quickly hand over to Fiona for dental. So just you'll see that you've got the overview there, which was discussed at the general practice and dental operational delivery groups. And then moving into the 2 board level risks that we've got. You can see in red that we've made a number of amendments for this month there, including changing the target delivery date, recognising the ongoing issues and the ongoing work around trying to improve the resilience of general practice. And you'll see quite a number of highlights there for November and January in terms of the work that is being done at the moment. I would just like to pick out that we are pleased to have been able to release some funding to general practice over the winter period to support with resilience. We recognise that general practice would have appreciated it sooner, but we're pleased to have been able to do it nonetheless. There has been some promising growth in the workforce, and we have been progressing the work at the interface with secondary care. The Queen Elizabeth Hospital has already launched ICE requesting for pathology, for example, and a new working group has been established at the Norfolk and Norwich with the James Paget to try and progress the work there, recognising it has been slower than we might have liked. So I think that's probably all I would say on the general practice side of things. And if I can just ask Fiona to come in, Debbie, if that's okay.
Yep, please, Fiona.
Thank you. Yes, so following conversation at the last meeting about the dental risk, we have reflected and updated the timeline, and that fits probably better with what we're seeking to do through our proposed dental long-term plan and the timeline associated with that. You'll notice that we're starting to highlight that there are a number of individual practices that may be at higher risk, and obviously we are doing everything that we can to support them, and detailed discussions will take place at the delivery group about those. And obviously now we need to reflect on what our long-term plan looks like in the context of the publication of the National Dental Recovery Plan last week. So we'll be looking at that and updating our plans accordingly.
Okay, all right, thank you, Fiona, thank you, Sadie. Anything from members of the committee on this? No? Okay, all right. Happy to have received and had that discussion on the risks then. Thank you very much. I think it's a really helpful format from, previously how we were doing it, to have that more detailed look into those critical ones. So thank you for that. Okay, so that brings us on to service development issues and the main sort of item of interest today, which is the proposals from Holt Medical Practice. Perhaps I could just say a little bit about how I propose to handle this item, if that's okay, and seek your cooperation about this. Absolutely recognising how much interest and views this has already brought about, and it's come to this point now for the committee to make a decision. So we have slightly amended the usual approach based on the sort of the constitution and the standing orders, because we felt it was important to make sure people felt heard. The officers will present the paper, and then I will ask committee members to ask any questions of clarification. And then I'll come to members of the public to ask questions. And I will be seeking your cooperation in that. You know, this is about questions to the committee and clarifications, not speeches if we can. My other request is that, you know, keep them as concise as you can. Ask the question you want, but I would ask that we keep them fairly concise. And so once we've covered all of those, then I will ask the committee to discuss the paper and reflect on what they've heard, and then we'll move to the decision. So with that in mind, let's get straight to the paper. So what we've got is we've got a covering paper from officers, and we've also got the submission and the request from Holt Medical Practice. And I know there are other appendices available should people want them. But Sadie, I'll come to you to take us through this and just highlight the main issues in the paper that you think we should be looking at.
Thank you, Debbie. So firstly, I'd just like to acknowledge, as I have in the introduction in the paper, the efforts of the practice, the local community and local stakeholders in the engagement process that has already been undertaken. And of course, members will recall previous discussions on this topic, as we've had a paper come at various stages of the process before. So Holt Medical Practice, as you can see, is a large practice covering a large rural area and operating from three sites. The practice has now confirmed through its submission that it is planning to proceed to submit an application to close the Blakeney branch surgery. And the rationale for that has been set out, I think, quite clearly in the submission that the practice has given us. The rationale, a few of the areas, and there are many, centre on business viability and looking to operationally future-proof services for patients, looking at succession planning for the partnership, thinking about how it can best use its workforce, and the difficulties in operating out of a small branch surgery in Blakeney, in light of the modern general practice access model. And the practice also has set out how appointments have been historically used by their whole population at Blakeney and across their other sites. As part of their application, the practice has offered to provide a residual medicines collection service in Blakeney with the agreement of the local community in order to mitigate the withdrawal of services. And as part of the process, I think it's fair to say the practice has done an extensive engagement process. And as officers, we were satisfied around the level of engagement and have also received confirmation from Healthwatch Norfolk that independently that they were satisfied with the level of engagement undertaken. I have personally viewed the engagement materials in the practice, and I know you have, Debbie, as well, and so has Hein.
Yep.
And we've seen the letters, the survey results, the petitions, and I think it's obviously clear to us that people local to Blakeney have significant concerns about the application and the potential impact, and they want the surgery to remain open. I think that's clear through the engagement process.
Sadie, can I just interrupt you? I'm conscious that there's someone trying to get into the meeting. I wonder if Sarah could admit them. I don't think I'm allowed to. I've tried and it's
oh, well, I've just clicked it. Oh, they
sorry to
can't seem
interrupt
to get them in.
Oh. Sarah, are you struggling too?
Yes, I am. I've got a number of people emailing saying they can't get in, so just bear with me and I'll try and find out a solution.
Okay, all right. Sorry to interrupt. Carry on, Sadie. Sorry.
I think just to say on that, we are recording the meeting, and it will be available on the website afterwards if there are any issues for individuals. So back to the engagement. I've lost my thread now.
Yeah, sorry.
Yes, I think the engagement clearly set out the views of people locally, and some concerns around transport for those that can't drive and for vulnerable people. As part of this process, the ICB has undertaken an equality impact assessment and a clinical quality risk assessment. And certainly the EIA pointed to some actions that we might take to include, for example, understanding what might be needed for certain groups for the practice's proposed medicines collection service. And I think that ties in as well with the practice engagement and the fact that we did see less detailed information coming through that process on the practice's proposed residual service. I mentioned in the paper that at the time of writing, we hadn't had any significant response from our letters out to local partners and system partners. And I can now report that we've had 6 responses, and I'll give you a little summary of those if I may. So there was concern about the impact on other practices in the local area if capital funding was diverted from larger estates projects into a Blakeney project. There was concern about the potential impact for Holt on how they would maintain quality of care across their whole population if their services were stretched. There was trust expressed in the practice partners and the team to have fully considered their proposals. There was a suggestion around potentially working with community transport and supporting digital accessibility for local people. There were 2 responses that offered no views, and there was 1 response that supported the application. So if I can just move to the options that I have suggested in the paper. The 3 options which we're proposing today, and of course you may have different views on these, is to agree the application, to reject the application, or to defer the decision and consider for the ICB to undertake some further public involvement to understand patient views on the practice proposal to provide a residual medication collection service in Blakeney. And that further information could help inform a decision. I think from an officer point of view, option 3 is the recommended option to committee members. And if this is agreed, then we would offer the practice a further opportunity to refresh their application before it is brought back to committee for decision. So we think that we can do that process given the extensive consultation that's already taken place, because it would be very focused, that we would bring that back, and we're proposing a committee meeting on the 23rd of April to do that. So today we are asking for committee to consider a recommendation to defer a decision on the application until the 23rd of April to enable us to undertake further public involvement. So I'll stop talking there. Thank you, Debbie.
Right. Okay, thank you, Sadie. That's very clear. So as I said, I'll come to committee members now for any questions or clarifications. So Karen.
Thank you, Debbie, and thank you, Sadie, for a really clear paper. This is more a comment than question at this point. And really, just to clarify, I think it's really important that we acknowledge the strength of feelings that we've heard back from the local population. I think it's really, really important. And more importantly, that we've heard what people are saying. We can listen, but we don't always hear. I also want to acknowledge that I think the practice have done a very good job in their engagement process, and they have also included Health Watch, which I think is important from an independent perspective. And for me, I would suggest or recommend, in my personal view, is that we go for option 3, which is about extending pausing at the moment, as Sadie has suggested, and doing further engagement consultation on the management of medications, because I think that's really important. That matters to people, and it's really important that we do that. I think what I've heard today is we've heard a very clear message from the consultation, but I think there are other key elements that we really need to take into consideration. And for me, one is around the environmental issues. Being the nurse on the call, I worry about the IP&C risk and the risk to accessing patients if the surgery should open. And I also worry about the longer term viability of the practice. And I just wanted to check with Sadie, because I know in the CQRA that has been considered, but whether we wish to have further discussion on that, Debbie, I'll open that up. Thank you.
All right, thank you, Karen. I'll come to Hein now.
Thank you, Debbie. I would echo Karen's comments on engagement and process followed to date. And on a personal note, it was good to visit the 3 sites. And as Sadie said, to be able to see a lot of the feedback that has been received. I have a question around option 3, Sadie. You say you're going to run some further public involvement by the ICB. Could you say a bit more how you're going to run that, who you're going to talk to, and maybe the timeline you envisage that will take? Thank you.
Thank you, Hein. So we're being supported by our comms and engagement team on this. And I think that what we would ideally propose to do is to have a conversation. There has been a local campaign group, there's the Blakeney Parish Council and other local councils. I think in the first instance, we'd like to talk to them, talk to the practice about how best to obtain the specific feedback on the area that we're looking for, in addition to that which we've already heard and I don't think needs to be repeated, because I think that's very clear. So we would be looking to work with the local community to look at the best way to obtain that.
Yeah, thanks, Sadie.
Okay, thank you. Any other questions from the committee? No, in that case, okay, great. So so I was kindly sent a list of people who wanted to speak. That's not exclusive, but if it's okay, I'll start with the people that I've been notified for, and I'm keen to start with residents if I can. So I wonder if Sheelin Cuthbert from Field Dorling wanted to ask a question. Sheelin didn't make it. Okay, we can come back. So I can see. I think I saw Tim Andler. Tim, welcome. Would you like to ask the committee your question? You're on mute at the moment. Oh, I'm afraid you're still on mute. That's it?
Right, is that any better?
That's better,
Can
thank
you hear me now?
Yes.
Well, firstly, let me congratulate this committee on the excellent work which it does. And thank you for that on all our behalf, because there's a lot of volunteering going on. On the other side of the coin, you've been considering what I have to call a mendacious application, such as that presented by the practice, a lot of which you seem to have accepted as true when it's not. For example, there has been no proper consultation between the practice and the patients ever on this subject. And when I addressed that with the senior partner personally, face to face, she said, get lost, basically. There would be none because she likes this system whereby they hear mostly from you, or you hear mostly from them, rather. And we would like to believe doctors, because after all, doctors should be believed. But I have an uncomfortable feeling that there's quite a lot of porkies in that application, and they have not been considered by you because we've had no chance of talking to you so far.
Tim, what is your question to the committee? Perhaps
I'm coming to my question. If you give me half a second, I'm nearly there. And what I will have an uncomfortable feeling that the main reason why the practice seeks to deny Blakeney patients the same service as Melton Constable's patients is that the partners would trouser considerable sums of money by selling the Blakeney surgery. I'm sure I must be wrong, but might I be right?
Okay,
That's
so your
the
question really is about the motivation and the drivers.
Yes, a lot of people here believe, and we may or may not be right, but we believe that the main motivation for Blakeney patients not getting the same treatment as Melton Constable, we don't want more, we just want the same, is that the partners will make a lot of money out of selling Blakeney site, and they wouldn't make much money selling Melton Constable.
Okay. All right, thank you. Okay, the next person I was notified about was Alexandra Hooper, Chair of Stukey Parish Council.
Stiff key, please, stiff key. Thank you very much.
It's a big debate, Alexandra, come on, it's a big debate.
Thank you very much for the opportunity. I think my questions, I've actually got 3 questions, and they blur along the lines between about inequality and access and outcomes and the environmental impact of the decision. I think, first of all, I mean, I do have to say that the paper and the census data and the information that it presented was for North Norfolk and not location specific. And I think it does skew facts because it puts the average age at 50, whereas I think you'll find that the average age around Blakeney is about 66 or 67. And I think it's important that we acknowledge that. And given the broadness of the data used, because it wasn't the practice actual coverage area data, I would like the ICB to explain how the case for closure of Blakeney surgery effectively considers the location-specific inequalities in access and outcome that closure will create, as well as the environmental impact of the need for increased travel and the way in which this will appropriately dovetail to NHS net zero aims, compliance with climate legislation, and the increased carbon footprint the increased journeys would result in. I would also think that if we're going with option 3 and further consultation is going to be undertaken before a final decision, that again, how will the ICB and obviously Holt Medical Practice revisit the proposal to take appropriate steps to address those very same issues? And then my third question is, will you, the ICB, give assurances that any further consultation and work before a final decision does use location-specific data as its basis, rather than a broader use of North Norfolk, which is not necessarily an accurate reflection of the situation? I think there's a real danger that statistics are skewing what the case is, and I think it's quite clear that this mitigation proposals such as prescription deliveries and volunteer car services don't address some of the environmental issues. They also don't necessarily address some of the inequality and outcome issues, and the talk about going digital again doesn't necessarily do this unless you drill down on your data, because the average 50-year-old is very happy to use digital services, but they might not want to use a car. And let's face it, the doctor surgery offering a in-person house call, if you are housebound, isn't going to apply to a 50-year-old because they're very likely not housebound, but it doesn't mean they want to get in a car and make a 20-mile round trip. So I do think you need to look at specific data in the specific practice area. Thank you.
Thank you. Thank you very much. I've got Nigel Sutcliffe, Vice Chair of Blakeney Parish Council, on my list next.
Yes, am I coming through clear?
Yes, you are, very clear.
What I wanted to raise specifically is a bit of the history of this, because I think it's important. What the people in the area want to do is to revert back to what we had in only 2019, which is a fully functioning surgery. Now, by stealth is the word I would use. The Holt Medical Practice have effectively closed the services down. They withdrew the dispensary, they withdrew face-to-face interviews. Then you get COVID. Now, the Blakeney Parish Council and the other parish councils in North Norfolk came onto the scene in November 21, when our public were telling us, you know, when the service is going to return to it. And we started a campaign then, and I stress it's 2021, to try and ascertain what's going on. The Holt Medical Practice have continually refused to change their position. They want the surgery closed. They won't enter any discussion about it. And don't forget, it was us that told them about NHS guidance on how to deal with closing surgeries, which they were not following and had deliberately ignored. The parish councils have always followed a patient-centred approach to try and get full medical services to return to Blakeney, whereas Holt Medical Practice seem, and I use this word carefully, seem to be unconcerned over the massive inconvenience they've created to the patients with regards to journeys to High Kelling and Melton Constable. The open meeting that the medical practice held at Blakeney Village Hall on the 1st of August, I think it was, to start their patient consultation phase. When you couple that with the 2 independent surveys that were conducted, they overwhelmingly show a majority of patients who want Blakeney surgery back open. Now, my question to your good selves is this. If this group do not act on the wishes of patients, as demonstrated in the report before you today, then who does look after the interests of the minority of patients within Holt Medical Practice overall patient base to ensure they receive access to NHS services locally as identified in national guidance? I can assure you as a patient that neither High Kelling or Melton Constable are close or easy to get to.
Great. Thank you, Nigel. Thank you very much. Then I've got Rosemary Few, who's the chairman of Blakeney Parish Council, I think.
Thank you very much. I have to say that Blakeney Parish Council is very disappointed with this report. It doesn't fully recognise the degree of concern, and I have to say even anger, amongst patients in Blakeney and the surrounding villages. The report is disingenuous in parts, for example, saying that the surgery reduced before the pandemic in response to patient demand. And a question, could you explain please how patient demand was assessed? My second question, Alexandra has covered some of this, but the report is very selective in its use of data. It shows the average age, as she has said, of North Norfolk to be 50.1 years, but is the practice aware that Blakeney has a much higher population of people over 65 than Norfolk generally? How has that been factored in? And what account has been taken of the fact that about 1/3 of the population of Blakeney live alone, suggesting a limited support network for transport to a remote surgery? My third question is around mitigation. Mitigation is completely inadequate. There is reference to some unresolved discussions with alternative sites in Blakeney, but most of the alleviation is based on the premise that people will attend the surgery. Will the practice please explain how patients are expected to get to Holt, or even worse, to Melton Constable, given the length of the journey by public transport, and that despite trying to recruit, there is still a shortage of voluntary drivers in Blakeney? Thank you, Chairman.
Lovely. Thank you very much. Okay, I'm going to go to Councillor Victoria Holliday from North Norfolk District Council, and then I'll come to Duncan Baker MP.
Thank you, Chair. Thank you very much indeed, and thank you very much for an excellent report, Sadie and Holt Medical Practice. I have a two-part question. Face-to-face doctor and nurse appointments, a significant change in service provision, were removed from Blakeney before COVID. We are told that this was with the support of the Commissioner. Given that we had previously been informed that formal governance processes were not followed at that time, is it possible to see the evidence of the Commissioner support for this change in service provision? Agenda item 9 today is an advice note for branch surgeries seeking to change their service provision or opening hours. I understand a lengthy consultation process with patients and stakeholders, both by the practice and the ICB, is then required. This consultation did not happen at the time hours and service were reduced at Blakeney Surgery. Why isn't the current advice to branch surgeries being followed, and a full consultation on the withdrawal of clinical services from Blakeney Surgery rather than just on medication provision now being carried out? Thank you very much.
Thank you, Victoria. Thank you. Duncan, did you want to sort of come in and ask a question that rounds off that? And obviously, if there are other people, I'm happy to take those.
Yes, thank you very much, Debbie. I guess you can hear me coming through all right?
Yep, we can. Thank you.
Lovely, thank you. Well, if you may just indulge me for a couple of seconds with the privilege of being a Member of Parliament and, as you know, and representing this area, that would be appreciated, and many on the call know me well.
2 seconds is fine.
Yes, lovely, thank you, Debbie. This is getting me back for that public meeting. Look, I agree with huge amounts that have been said by residents, obviously elected members as well. And the first thing to say is obviously this has been a hugely concerning in the local community. We've done our own, or my office has done my own research in when we went out and surveyed how people felt about this decision. And I just want the whole panel to just be aware of that. We had 434 responses to 1,700 letters which were sent out. Now, for those quick at maths, that's about 25% of people responding. You never get 25% of people responding to a survey. That just shows how concerned people are out there in the local community. And 91% of people told us that they were users of the surgery. That's a very high proportion of people in that local area. And 99% said they were in total disagreement with having the surgery shut. 96% of people told us if the services were restored, they would use them. So let's just put the context out there. We are in an extremely elderly, vulnerable, as been said by other members, average age is approaching 70 years old. And that is why that even given what Chris Whitty has said recently, specifically mentioning North Norfolk, ask yourselves, this is the wrong decision at this moment in time in the 21st century to be shutting rural, coastal, in a very elderly cohort area, medical services. And that is the absolute encapsulation of all this problem. So look, ask yourself the financial viability and the staff resources. Financial viability, yes, there's information in that pack, but look at the area we're in. Holt Medical Practice is, I suspect, one of the few places in the whole Norfolk region that will really struggle with recruiting GPs, given the backdrop of being in an extremely beautiful and lovely area such as Holt and having Gresham School on its doorstep. And you've seen that in the information of the numbers of GPs and the numbers of patients that they serve, that actually it is not struggling to the same degree as other areas. So all of the signals are wrong for that very frail, vulnerable area. It is a huge round trip for elderly people to take a bus route to visit Melton and Holt, and that really hasn't been set out in the mitigation. So I just want to pay a quick couple of seconds on that mitigation. The mitigation here is absolutely not by any means at all appropriate. You know, extending the sheltered canopy or giving a bus system to Holt. Come on, if you are going to go and take forward option 3 as the mitigation, which I'm a realist in all this, I am a realist to what is going to happen here, then the least you can do is look at the mitigation properly and come up with something that really will safeguard my residents for the future. And so as I end, the 4 things I would particularly like the panel to look at when they come to mitigation is that really some kind of hub, some kind of facility that does still allow face-to-face nurse or GP appointments, rather than completely and utterly accepting that it is going to have a closure. We still deliver on that through the week. But the medication collection, the maintenance of current medication ordering and collection service for 5 days a week, absolutely you find the right place to be able to do that. Transport is totally key in this. We cannot have a situation where very elderly and frail people in their 80s and 90s just do not have the transport to be able to get to Holt or Melton. And of course, it makes a total mockery of the net zero obligations that you have. And then some kind of well-being clinic for prevention purposes to help people with their health and care going forward to also be prevalent in the community. But above all, as I end, ask yourself, is this the right decision to close vital medical services in a very, very elderly and rural community? And I think you all know the answer to that. And therefore, put the right mitigation in place if you're going to end up with a decision that I think I know you're going to have. Thank you.
Okay, thank you, Duncan. Thank you very much. Just before we move back to the committee members, I just want to make sure that there aren't any other members of the public who I didn't have on my list who would want to ask something. No. Okay. All right. Well, in that case, can I thank you very much for those questions? They're well thought through and reflect admirably on the work that you've all done and commitment to the area. So thank you for that. Okay. So committee, having heard that and I'm sure that we will provide sort of more formal answers to those. I mean, the things that I heard in there were about the data, were about the drivers behind this, about the mitigation and particularly the census data and previous decisions and how they fit with the right process. In summary, those are what I heard. So colleagues, let me open it up for reflections, views, and then we'll move towards making a decision about the options. Who would like to come in first? Karen, I wondered if we circled back to the issue that you raised earlier, but I'll let you come in.
Yes, of course. I raised my comments earlier. I was probably a bit premature in that, but I think it's really important to have heard. I think the questions were really well thought out and require careful consideration. I think from my perspective, there are still some unanswered questions. And I do think we need to recircle back to option 3 in terms of looking in more detail in terms of the public involvement in terms of medication and other, perhaps look at the EIA again just to make sure we've captured everything. Thank you.
Okay, thank you, Karen. Other members of the committee? Hein.
Yeah, I also, having heard various people talk after Sadie, I do think option 3 is the right way to go at this stage. I think, as Sadie said, it's been a very thorough process, but we also heard from various people saying elements missing, and hopefully the time that option 3 allows offers the opportunity to deepen some of those, go into some of those questions. So supportive of that. I heard the environmental aspect as well, so let's make sure that is properly addressed in the next stage. But that's where I'm at, Chair. Thanks.
Okay, thank you. Any other comments or questions or reflections from members of the committee? No. Sadie.
Thank you, Debbie. I just wanted to clarify that we will publish questions and answers in due course. Thank you. So we've been feverishly scribbling them all down, and we will make those publicly available on the website. I couldn't possibly go through all of those points that we've raised, but I'd just like to draw on a couple, if I may. So when we consider any application, as you know, this is clearly set out in the policy guidance manual that we use. And what we do have to consider is the entire patient population in a particular practice. So we will be carefully using the equality impact assessment and the clinical quality risk assessment, but it will be in the context of the entire registered population, as well as considering the people that are very local to Blakeney, because the practice has a contract with us to deliver services to its entire population. So I just thought that that might be a helpful helpful comment to make. I think there was I think it was Victoria that raised the issue about commissioner support, and we are in correspondence with Victoria and Blakeney Parish Council separately on that, and so we are working on that now. And the advice note on the agenda, I think what we are trying to do is to clarify the process for the future, and it wouldn't be appropriate to retrospectively apply a process that hasn't been approved yet. So it will be very helpful for us and for practices moving forwards. But that is recommended for your approval later on the agenda. So I've taken all the other points on board. We will draft responses and make sure they are published in due course. Thank you.
All right, thank you, Sadie. So I don't see anybody else. I mean, you know, I agree with Karen and Hein around the recommendation. I think doing that further work is really important to cover off those areas and to take the opportunity to reflect on what we've heard and look at those other things in the EQIA and in the mitigation. I think that is beholden on us to do that. Just a reflection really that these are difficult decisions for everybody involved. You know, at this time in the life of public services, these are hard decisions to make. And the intention is to make those in an appropriate way in taking into account the things we need to do. I do want to publicly thank the primary care team and the practice and everybody who has contributed to this. It's a tricky one, so I just want to really acknowledge the work that has gone in behind there and to thank officers for that. So unless I hear any voices to the contrary, I propose that we go with the suggested recommendation, which is to defer the decision for today and to undertake that further public consultation in line with the recommendation on the paper. Is that agreed? Nods, I see. Okay. All right. Sadie, is that sufficient for us to do this? I don't need a vote.
Yes, thank you.
Right. Okay. All right. Okay. Well, members of the public, this is a meeting in public. You are most welcome to stay with us and observe it, or you might want to save up the recording for later and watch it later. But can I thank you very much for coming and for your help in making this a really helpful discussion. Thank you. So that takes us on to, I've now lost my agenda. So that takes us on to the joint forward plan for primary care. And this is for noting. Who is it I'm coming to for this, Sadie?
Me, please, Debbie. Unfortunately, Ollie's not in today.
Okay. Oh, yes, you did say, sorry.
Thank you. So it's a very brief paper, and I'm going to assume that that members have had the opportunity to read it, and it builds on the paper that you received a little while back, giving the former update, and you can see the previously updated items are also included as a reminder. So the two areas for us in our joint forward plan commitments were around developing our vision for providing a wider range of services closer to home, improving patient outcomes and experience, and stabilising dental services through increasing dental capacity in the short term and setting out our strategic direction for the longer term. And that was all under the heading of trying to seek to improve the resilience of primary care in Norfolk and Waveney. So I think at this stage we are drawing to your attention that unfortunately, due to resilience issues and competing priorities for the teams, we are running behind. And we have reported this internally through the Transformation Board, but it's likely that the overarching strategic vision will be delayed, and we are planning our engagement process to start later in the year. We've already started it with dentistry, so we don't want to bombard everybody, but we will be planning a programme of engagement throughout the year. And then for dentistry, we've highlighted there's some fantastic work that's been happening to implement the short-term dental plan there. And again, we highlighted earlier under the forward planner that it's likely that instead of it being in March, it's going to be in April that we bring the dental strategy and the workforce plans to committee at that point. So I wasn't planning to say any more than that, Debbie, unless there are any questions.
Okay. Thank you. I'm conscious, obviously, since we last met and it probably cut across the timing of this report, we did get the national announcement around dentistry. I don't know whether anyone just wanted to reflect on how that would feed into this, whether, you know, there were unexpected or new things in there. Just a quick reflection without putting you on the spot.
I'm happy to briefly update on that, and Fiona can fill in the gaps. I think yeah, it was great to see the national plan being published, and I think what was reassuring for us is that we were already working on most, if not all, of the areas that were put forward for improving access and recovering dental services. So what we are going to be doing is looking at those in much more detail, just to check whether we need to tweak anything that we're already doing, and obviously build the rest into our long-term plans. Fiona, have I missed anything in that?
I think you've covered it very well. I'd just add that it's worth pointing out that there are a lot of within the plan. There are also several initiatives that involves working with local authorities, and of course we're already working very closely with both Norfolk and Suffolk County Councils around children's oral health, and we will be looking to expand that to include adults. So again, it's building on a lot of work that's already happening.
Okay.
But we'll be happy to bring I suppose a review and reflection to this committee once we have some more information, and we can also share how it impacts our planning.
Okay, thank you. It was a very good Radio 4 programme about it. I'll send people the link. I'm an avid podcast listener. It was a really good one. It will introduce the nation to units of dental activity, which can only be a good thing. Jason.
I apologise for my late arrival. Thank you for the brief opportunity to speak. I just wanted to say, first of all, to congratulate the local team for being swift with initiatives to support dentistry. However, unfortunately, the recent plan announced doesn't provide, sorry about this, doesn't provide the one fundamental thing that the dental profession needs, which is a significant change in the contract. There is no sign of that, and unfortunately it's going to be very difficult to support all of the practices in our region or to encourage more workforce back into the NHS without that change. So I applaud all the efforts of the local team, but they are trying to run a marathon with their legs tied together when it comes to this current situation. So please do not expect too much, and please do not criticise the team for not being able to deliver miracles.
Thank you, Jason. Thank you. Okay, that's great. So thank you for the update then, Sadie. Oh, I've got Bill who wanted to come in.
Just while we're talking about dentists, and I mean, is it worth the committee having an opinion on the dental contract? Because obviously it's a national thing rather than something in our own gift. So following on from Jason's point, is that a view that we should express as a committee in order to help create, facilitate change in the centre?
I wonder whether when we come back, I can't remember now which meeting we're coming back to with the stuff, Sadie, whether it would be helpful at that point to unpack the issues around the contract a bit more and almost demonstrate what we could do if the contract was changed versus what we can do. And maybe at that point, that will crystallise what the committee's view is, and it might be that we want to reflect that to government.
Yeah, we're proposing a 23rd of April meeting that we add to the calendar. Would you mind if we took that offline? I'm just very conscious that the team is focusing on the long-term plan and the engagement piece of work at the moment. And obviously, if we can make it for that date, then we will. But would you mind if we just took it offline and we added it to the forward plan, but just worked out how quickly we can do it first? Thank you.
Okay, that's helpful. Thank you. Okay, so we're happy to note this helpful discussion, and good to have that update against the joint forward plan, which is just a reminder, really key document. So it's really good that we are in this, that we keep coming back to this. It's a critical driver for the ICB. So that moves us on then to the advice note for branch surgeries. And we touched on this in the earlier discussion. Fiona, is this one that you're speaking to? Thank you.
It is. Thank you, Debbie. So I'll take the paper as read. We're asking the committee to agree the advice note that has been developed so that we can embed that within our policies and procedures and work with practices going forward. It complements our other advice notes, and I think following queries that we've had from several practices recently about wanting to change maybe their opening hours either temporarily or permanently, that it was helpful to have an actual process set out for both us and practices to follow. You will notice that we've highlighted the part in the policy manual around branch surgeries, and it says that unless there are specific reasons for variations, branch surgery should be held to the same standard of service as the main site, unless there is specific reason for a lesser service provision. I think we would acknowledge that Norfolk and Waveney is a large geographical area, rural and urban sites. So what we've tried to do in our advice note is give examples of the factors that would be considered when the committee or the delivery group is asked to agree any changes. I think it's also important to highlight that patient engagement by the ICB and the practice is reasonable and proportionate. to the change that's being requested. And obviously we have a duty to engage with other key stakeholders as well, and we'll ensure that that happens and that practices are supported. What we've also tried to highlight that there may be temporary changes and permanent changes, but what it doesn't remove is the practices requirements to invoke their business continuity plans. Should that be the right approach? And in that case, obviously practices will be informing the ICB, and we'll follow up with them to discuss next steps. The proposal is for the advice note to take effect immediately, but what we will want to do is to baseline where we are with all our branch surgeries. That will take a little bit of time to go through that process with all of our practices. So if committee agrees, we are asking for that advice note to take effect immediately. And finally, I'd just like to acknowledge and thank the LMC. They've been incredibly helpful in helping us to develop this advice note. So I'd just like to reflect that in the minutes, please. I think I'll stop there, and if there are any questions, I'm happy to take them.
Okay, thank you, Fiona. So can I just get my head around this? So clearly there are NHS regulations that guide this process, and this is a sort of an advice note for how those guidelines, if you like, should be followed and what the steps would be for Norfolk and Waveney. Is that right?
That's what we're trying to do, is actually offer our practices advice about how to the factors that would influence any decisions they might come to us for approval about.
Okay, thank you. Karen.
Thanks, Debbie, and thanks, Fiona. I think this is very much welcomed, Fiona, in terms of having a really clear process of how we should approach things. And I think it offers quite a degree of transparency that we have a process that's written down. We've obviously done things in the past, but actually we've never had it written down. And I think that's really important, because that will support us in increasing public confidence in our decision making and the process we follow. Thank you.
Thanks, Karen. Hilary.
Hi, thanks, Debbie. I was curious really as to how old the statement was from the NHS about branch surgeries having to operate to the same standard, because we all know primary care is changing quite fast, and the primary care team now is not the primary care team that it was even 4 or 5 years ago. We have a lot of extended roles, additional people working in our teams, and it's not practical or safe to have those people necessarily going out to branch surgeries, and branch surgeries in this area don't have the capacity to cope with that. So inevitably there'll be a discrepancy between what's provided at a branch surgery and what's provided at a main site. So I was curious as to how old it was, and I think what was really important for me is the mention that you have to look at the whole picture and the whole population. It is very difficult when you are the person with oversight of a whole team of people. You're the backstop for lots of decisions, lots of queries from a whole range of people these days, as well as seeing your own patients. And the different working arrangements need to be really factored into how we look at these things, because it is a very different situation to work in than there was 4 or 5 years ago. So a comment and a question, really. Thanks.
Don't know, Fiona, whether you're able to answer the actual question in there.
Yes, I mean, I think Hilary raises some very good points, and I think that's why it's so important to have a clear process for making the decision, so that we can consider all of the factors involved, and we recognise that general practice is evolving and developing, as you rightly say, due to the team that's now involved, the use of technology and digital. So it is becoming a more complex process. So I think that's why it's so important to actually have this open, transparent process to inform the decision making.
Okay, thank you. I've got another hand up. I can't see who it is. Katie.
Franklin.
Hi, Katie. So
Hello.
I'm happy to bring you in. I'm keen that we don't revert and open up the last item, because I think that would go against the sort of the openness and transparency, but happy for you to ask a question if you wanted to.
I stayed on because I was interested and obviously have potentially useful insight into what this feels like on the other end. I'm really positive about being there something set out. I think it's very helpful. I'm really concerned about the imposition of a high level of bureaucracy and unrealistic timescales around something that previously has been able to be run, I would like to think, well, and with all of these things considered at baseline level. And when there's such differences in what main sites are providing between surgeries, it seems odd to fixate on the branch sites. And there's not necessarily any guarantee of timescales in here, or actually what engagement has to look like for it to pass the test. And we know from today that there are different views about what that should look like. So if this is a final version, I would say that it's lacking in some detail that needs to be considered after the experience of item 7. That's just my feedback.
All right. Thank you, Katie. Thank you. Maybe Fiona, you could take that on board and maybe reflect on that. And I don't know whether there are any footnotes that might be added, because I think it's a valid, you know.
Yes, yeah, we'll take that on board, and thank you.
Okay. Okay, so so any other comments? Otherwise, we are being asked to approve this today. So overall, you know, helpful to have something set out, a recognition that, you know, life moves on and general practice from, you know, whenever is very different from today, and also the reality of actually applying this, given you know what we know this can entail. But with those reflections and caveats, perhaps can we agree this then? Yes, good, excellent. Okay, thank you. So this takes us on to our 2 operational delivery reports. So starting with general practice. So Shepherd, is this yourself today? No? Sadie or Fiona?
Yes, I'll happily pick up the general practice
Right.
one, and then I'll hand over to Fiona. So thank you for the feedback that you've provided previously on the report. We're still very keen to hear feedback to see whether you're getting the information that you need as part of the establishment of these new groups. So we've tried to put in much more detail from the meeting last time so that you can see what's being discussed in there. And I think if I just pick up on a couple of points from the January meeting, you can see there that the annual e-declaration, this is a contractual requirement for practices. We looked at it about a year ago, and I think at that point we had 4 practices that hadn't participated, which was a bit of a concern. And this year that has improved slightly, and we had 2, and both of those were for good reason, that unfortunately they were unable to comply. One bit was because of a change of provider. The requirement came right in the middle of a contract transition, and the other one was due to sickness. And in both of those providers, we have very regular contractual meetings in place already. So we felt that the risk was relatively low, given that we're in a contract monitoring framework with them anyway. The other area that I would like to mention is that in response to the audit action plan that you will have previously seen, we'd made some good progress on thinking about how we could start to monitor the PCN directed enhanced service. And then there was general support for that paper, but it couldn't be finalised until the organisational change process was completed. So once that's been published, then we'll be able to confirm with the different teams who will take responsibility for what. The items for escalation remain the same, in that we're still really concerned about the resilience of general practice and of community pharmacy as well. Across Norfolk and Waveney, there are a number of different contractors we're working with directly to support them, as well as thinking about wider system actions we can take. And we are continuing to experience capacity issues within not just the primary care team, within several teams across the ICB due to various reasons. So it is meaning that we have to focus on the high risk areas, and some of the more proactive work is having to be slowed down as a result. So happy to take any questions, or we can move straight to Fiona. Debbie?
Okay. Any questions on the GP one? Nope. Okay, let's go to the dental one.
Thank you, Debbie. I'm going to provide the dental report update today. Slight change to the agenda list of responsibility. For reference and minuting, I'm William Lee, Senior Commissioning Manager for Dental. I'll take the report as read, but provide a brief oversight of the contents for noting. The first item to note, this report covers the Dental Operational Delivery Group held on the 14th of December. The meeting on the 11th of January of this year was stood down. The group received a verbal report from the quality team. It outlined their efforts on reducing health inequalities and their collaboration with the Vulnerable Adult Service, and that received praise. There were 3 papers for approval. The first involved merging of 2 contracts within the same practice alongside an increase in UDA value. This was approved to ensure the provider had time to stabilise their financial viability moving forward. The second paper was for approval for requesting a temporary reduction in UDAs, but an increase in UOAs due to their makeup of workforce. That still mix enabled them to take on more orthodontics patients at present, and considering the long waits in the region and with LDC support, it was approved until the end of this financial year. The final paper was approved for the 12-month extension to the electronic referral service, with an independent review to be conducted to consider the current performance and inform a longer-term procurement with clinical input over the course of 2024. There were no new items of escalation highlighted, and as Sadie has already stated, any feedback on how we can improve these reports going forward would be welcome. Thank you.
Great, thanks, William. Okay, any questions or clarifications on that? Mark.
Thank you, Debbie. And I should just say thank you, Sadie, and thank you, William. You did a far better update than I would have been able to give. And so just to say, I chair both of those groups. And just from reflections as chair, recognising they've only really been in place for a few months now, 3 or 4 months. I think they are very useful groups. Hopefully the committee finds the reports helpful, but actually in terms of the work that we do, and as an ICB and a system, I think we are gaining something from those groups. We will be working with members of those groups to kind of get the feedback formally over time, but I just wanted to share my reflections and thank you to people like Sadie, William, Fiona and many others, Shep and others who do a lot of work to support that. It's a really good opportunity for us to get under the skin of some of the issues in general practice and dentistry. So just thought it might be helpful to share my reflections. Thanks.
Yeah, thanks. Thanks, Mark. And I think we've reflected in this group that it is enabling, this committee to focus on the bigger sort of strategic issues, but actually it's that sort of grassroots understanding and the work that you're doing there that informs those really. So I think the two complement each other very well. So thank you. Okay, so I think that's great. We note both of those, and that then takes us to the finance report. So I think, James, this is probably you today.
It certainly is, yeah, thank you. So as usual in the finance update, I'll treat the report as read, but just point out the key updates. So as we moved into month 9 of the 23-24 financial year, the ICB is currently forecasting to underspend by £14.8 million across the prescribing, primary care and DOP areas for the full year. This is a substantial shift from the last set of numbers I reported to this committee, but this can be predominantly attributed to the movement in the dental forecast. The ICB has recognised the estimated dental underspend for the 23-24 contractual clawback. Moving on to the financial summary, where that total underspend is broken down, there are 3 key areas of variance. Firstly, the GP prescribing. This is currently showing £4.6 million overspent. The majority of this is due to the usual cost pressures around SGLT2, CGM, DOACs, and a temporary reduction in our largest rebate for Doxpan. There are also pressures within the oxygen cost centre and some slippage in efficiencies. Second area is within dental co-commissioning. This is now an underspend once offset with LCSs. This is due to the additional recurrent allocation that was awarded back in month 6, which was agreed to pay down the historic underfunding within this particular cost centre. And then the third is dental, as I described before. It's now showing an underspend due to multiple factors. Firstly, due to the handing back and reduction of some current year dental contracts, creating a positive variance against budget. And secondly, due to the performance adjustments that we've now recognised for that 23-24 clawback due to reduced activity. They are partly offset by new investments in emergency and children's pathways and the workforce initiatives and some UDA uplifts and revisions that have been made in year. The next few sections of the report are the detailed variance analysis. I'll leave those for your own reading, and then just move on to page 9, which is the off-ledger reconciliation of that potential dental reserve that could be available for reinvestment. It shows the affordability of the investments we've already agreed and gives an indication of the level of clawback and underperformance that we've now recognised in 23-24. We'll continue to update this each month based on the activity data that we get from BSA to show that overall picture. Moving on to section 7 and 8, Optom Pharmacy. They're now showing overplan in combination at £1.1 million. In Optom, this was due to an increase in activity within site tests and funded glasses, and more significantly, home or domestic visits. Conversations with commissioners indicate this is more to do with the temporary availability of Optom resource within and locally to Norfolk, and not an indication of an ongoing trend. Pharmacy increases are mainly due to increases in activity around advanced services. And there are some early indications from NHS England that there will be some additional allocation to be able to cover this increase in activity. The finance team will continue to pursue this and report back in future reports. The next 2 sections, the efficiencies update. This includes the update to month 9. It shows a £0.9 million underachievement on the planned efficiencies, which represents about 7.7% of the total planned efficiency. The pod scheme being the largest area of slippage within those schemes. Finally, the last section, section 10, this is an update on the LCS activity we've received up to the point of the paper being written. This does highlight areas where we have less activity than were planned around, so this is for around mental health, SMI health checks, care homes, eating disorders and inclusion health. We need to continue to monitor this, but overall our utilisation at the moment is still very high at 99%. The Q3 figures are currently being finalised, and we'll be able to show those at the next update. So that was all the areas I was going to highlight. If there are any questions.
Karen.
Thanks so much, James. And it's not so much a question for James, but with the information you've shared, could I just ask, how are we evaluating some of the new investments we've made? I'm thinking in terms of dentistry, and are we realising the benefits from it? So if we've invested in new services, can we demonstrate that it's improved things?
I don't know if Fiona has an answer in terms of the sort of the qualitative side of that. Obviously, we understand what we've invested, and we can very much see that. But I don't know if there's any more areas around the benefits that we're getting.
I think, Karen, you raised a really important point, and certainly with the urgent treatment service, we're planning to bring I suppose a first quarterly report to the dental services delivery group to look at the activity. But we're running at about 1,000 appointments per month, with sort of DNAs at 2 or 3. So I think that's a positive intervention. And obviously any other investments we make, we need to find a way to evaluate them. And monitoring is a combination of lots of different data sets.
Okay, thank you. Hein.
Thanks, James. I had a question on section 10, the LCS activity tracker. I'm not sure if it's a question for you, but there's probably a story behind why diabetes is higher and SMI health checks are lower. So maybe an ask for a committee meeting not too far in the future to get a bit more of the story behind why we see the variances. Because I'm concerned that, for instance, SMI health checks are below budget, because it probably means we're trailing what we need to achieve. So it's a broader request, but triggered by your overview. Thanks.
Yeah, I think we can bring that back, and we certainly know there are some historical, and there'll be some historical trends to that activity we've certainly seen within LCS. So I think we can probably reflect on that and bring that back.
Okay, thank you. Just checking. James.
Yes, thank you very much indeed. 2 questions. One on the underspend in dental services. We have been told, I think relatively recently, that dental spending will be ring-fenced, and therefore have you got reassurance that whilst we still have an underspend for all the reasons that everybody knows, that we will be able to keep that to take the benefits when the new systems come into play, being very optimistic that the latest announcements will bring some good news. I say optimistically. So that's just one. And then secondly, on the eating disorders, at 67% of activity, which I think, apart from the other 2 at 59, is the second, third lowest. Is this because of other partner organisations having initiatives that are addressing this, or is this just something that we are struggling to get people to engage with? Thank you, Chair.
So on the dental activity, so absolutely, it's a ring-fenced budget, which means that we cannot move it anywhere other than what it is. So all we are able to do is look to reinvest within dental services as much as we possibly can, and much as within the resources in the area allow us to do so. We are limited within the financial year, so at the end of the day, when we get to the end of this financial year, what we've spent is what we've spent, and then the budget should then be reflected next year, because it is a ring-fenced budget back to what we were originally allocated as such. So that's where we are in terms of that dental allocation.
Chair, could I just come back on that? So at the end of the year, if we're underspent, that will move forward into a ring fence. I thought that may be the case.
No, sorry, no, it will be an underspend. Absolutely, it will simply contribute towards the overall ICB financial position. Absolutely, there's no ability to move that into next financial year for us at all.
Right. So we've got a big task to catch up. Thank you.
Shepherd.
Thank you, Debbie. It was just to come in on the LCS, just to say it's good to actually see the LCS broken down in this way. It does connect to our operational efforts that we're making to strengthen on the LCSs. Then to come to Hein's point about having an item come back, it was to say we've done a great deal of work, and I'm expecting this item to be heard in more detail at the operational delivery groups. So I would expect what probably this committee will have is a summary in a report, rather than to have a full discussion on the LCSs, if that is okay. Then just to make a comment on the SMI and also the inclusion health, I think it's fair to say the numbers are Q1 and Q2. So whilst it's showing the low percentage in that, it does not necessarily mean that at the end of the year it will be low. But the comment I would also make around those areas is the reporting for SMI is a lot more complicated, and there's still further work to be done to actually appreciate the good work that goes in there. There are a number of components that are involved. So if you do 5 out of 6, that does not count. So there's still some refining work that needs to take place at a national level regarding those. I'll probably just stop there, but.
Okay, thanks, Shepherd. Thank you. While I've got you to speak, before you turn your microphone off, what is proactive healthcare? What does that actually entail?
I'm tempted to defer because I know that this is a very, very area of interest because it's got a long history with it. So I'm sure Sadie can feel it coming.
Go on, Sadie.
Yeah, so this is a service that was offered to practices using a historical funding pot that was slightly differentiated depending on which locality and which original CCG the practices formed part of. So essentially, the service specification allows practices to come up with a service that's specific to their population, which is designed to provide proactive healthcare to prevent use of urgent and emergency services. So we have a really different range of services across the patch. It was something that was very new when it was introduced, and the plan is that it will be evaluated because all practices submitted a baseline when they set out their original plans, and that we would be able to then review how successful the schemes would be and consider that in any future commissioning arrangements.
Okay, all right, thank you. Jason.
Thank you, Chair. It was just concerning the question that James had concerning ring fencing. It's just clearly there can be a misinterpretation of what that means, as in, there can be a sense that all of this money exists and all of the money will be spent on dentistry, where clearly with a very reduced workforce and a number of practices who have left dental provision, there's only so many avenues to spend that money. And of course, I would never accuse any members of the team of this, but there's a slight moral hazard that if you've got overspend elsewhere, then knowing it will revert back to the rest of the budget at the end of the year could encourage perhaps not the most imaginative use of the monies. But clearly, it is unlikely that all of that dental budget will be spent, and that could be a problem that snowballs over time as we lose dental provision.
Yeah, thanks. Thank you, Jason. Yep.
Chair, could I just come back on the other point about the eating disorder and Shepherd's comments about the other? Is that the same for eating disorders? My observation was that other partner organisations may be doing more work in that area, and therefore the ICB and this funding stream is not being used to its full capacity because others are doing it. Is that right?
I can see Sadie has raised her hand.
Yep. What, Sadie?
Well, I'll do my best. So each one of these services was costed differently in that for some we had really good data. So if you look at the SMI health checks, for example, there's a really clear register of patients, and therefore we budget on the basis of the number of patients that we know are entitled to receive that service. For something like eating disorders, we did our best to try and set out how many patients we thought that would serve, but it does change from time to time. So I think don't read too much into the uptake figures, because we moved from an arrangement of block contracting, block amounts of funding, into something that was activity based largely. So it has taken time for us to understand some of the data and for all of this to settle down. So sometimes it will be because the uptake isn't there, and sometimes it will be just because there aren't the numbers at the moment.
Thank you. James, you wanted to come in?
And absolutely, what we're saying is correct. This is only up to the Q2 claims, so we could end up as well towards the further 2 claim periods having a higher uptake there, and that does happen with practices as well when things are claimed later in the year as well. So I think we probably need to reflect on it once we get another quarter at least in there.
Okay, Shepherd.
Just to make an additional point to this, I think, James, there is a clinical component that is also included in the numbers that probably we should surface in that. Not all practices have got the capability to provide for eating disorders, and we've got some gaps in that space. So that could be also an element that plays into the numbers.
Okay. All right, it's provoked a lot of discussion, that table, hasn't it? It's really really interesting, so thank you. I think it'd be good to circle back to that at the right time. Okay, so I'm sure you know, colleagues in the room have sort of got this in mind, but I guess it does feel counterintuitive to to be reporting publicly or forecasting an underspend in an area where everybody is crying out for service. So, I guess the communications around that and the explanation and that will be important if we continue to take people with us as we're trying to grapple with these things, really. Okay, so had good discussion about that. Happy to note the report. Thank you very much, James. So that takes us to any other business. I'm not aware that we've had any notification of any other questions. We have. I apologise, Alexandra.
So sorry, I normally I do try and send my questions beforehand, but this one actually it's come about as all the reports today on dentistry. And I recognise that you're trying to do lots about this, and one of the things I wanted to ask is, how are you sharing this with the public? Because I get asked lots of the time, well, what's happening, what are you doing? And other than if you don't attend this meeting or see the papers, actually you don't know just exactly what is going on. And I'm thinking that, dare I say, some of your underspent budget may be well worth spent on actually trying to find a way to let people know what is happening. That I don't know if there is something going on that I'm missing, but I just thought, yes, my question would be, what are you doing to tell people?
Yeah.
Thank you.
Thank you. Thank you. Who wants to step into the fray? Sadie.
No, thank you. And I think this is an area where we can always do more. And I'd just like to reassure you, we held a briefing for all of the Norfolk and Waveney councillors about 3 weeks ago, I think it was now, to launch our engagement process. We have in the past held briefings for all the Norfolk and Waveney MPs as well. And we use social media. I've been on the radio recently to launch our engagement campaign as well. And I think we have a dental page on our website with all of this information on as well. But we're always really keen to hear where we could do more. So suggestions are very welcome. Thank you.
Yeah, yeah, I think that's right. I mean, what you know, I do think it is a good question, Alexandra, and I am aware of the work that Sadie and the team have been doing, which I know has been well received. But when it comes to these sorts of things, you know, the message always is you can't rely on one thing. You have to constantly be communicating, finding different ways. So, you know, I think that parish councils as well might well be an important audience, and you know, it might be that we could ask certainly the districts to engage with district councillors having had that presentation, or perhaps we could do certainly send or host something. I hate to burden Sadie with more, but for parish councillors that might be really timely. James.
Yeah, sorry, could I just add to that? And the latest announcement of the dental improvement, in inverted commas, on last Friday. I mean, some of the items in there, Sadie, Fiona are already doing, e.g. working with schools. There is an initiative that is already up and running. So, you know, just let's remember that Norfolk and Waveney are sometimes ahead of the curve. And I think we could teach some of the powers to be further down, or up, or whichever way you want to call it, some of the lessons that they need to take heed of. Thank you, Chair.
Okay, thank you. Alexandra, I'm not sure if that's a legacy hand.
No, it is. I just wanted to come back on that and actually just say that, to be honest, you always seem to get a lot of grief, and this is one opportunity, I think, where you could actually blow your own trumpet of actually doing something very proactively. And I know it might create more work, but I think people having an idea that there is a plan actually, and the plan takes time. And I think it would be really worth getting out there and trying to do something to distribute that information. Because actually, like I say, it's not very often you get to say, well, actually, we are doing something and we are being very proactive. And that's all really. I think it could be an opportunity to take if you could.
Yeah.
Thank you.
Right.
Anyway.
Thank you very much. Thank you. Okay. Okay. So unless there's anything else, I think that draws this to a close. We've got the next, it's 12th of March. Is that right? Yes, it is right. Yes, good. Okay, so the next meeting of this is the 12th of March. Okay. Thank you very much, everybody. Thank you for all the work that's gone into today's agenda. Really appreciate all the contributions. Thank you very much.
Thank you.
Thank you very much.